and welcome to the presentation. I see there's quite a few people online already. Today's speaker is Dr. Emmanuel Taban. He is a South African pulmonologist, originally from South Sudan, whose extraordinary life journey has made him one of Africa's most inspiring medical figures. He escaped civil war as a teenager and arrived in South Africa as a penniless refugee. He then went on to study medicine at Medunsa, specialize in internal medicine at the University of Pretoria, and later qualifying in pulmonology. He's currently practicing at Mediclinic Midstream and previously had a practice as Mediclinic Highveld in Secunda. He is renowned for his expertise in complex lung diseases and for pioneering the use of fiber optic bronchoscopy during the COVID-19 pandemic to save critically ill patients. He has been recognized internationally as one of the 100 most influential Africans and honored with awards for his humanitarian service, embodying resilience, innovation, and dedication to patient care.
Thank you, Dr. Godinho, for a really lengthy bio. Thank you. Okay, today I just thought perhaps we need to discuss COPD. You know, everywhere you go, every corner of the world, every new admissions is all COPD. And I think it's one of the really something that we encounter on a daily basis, either as a general practitioner practice, specialist physicians, pulmonologists, or even non-surgical, non-medical disciplines like surgery, surgical disciplines like orthopedics, and you talk about surgery, most of they would encounter patients with COPD. So I thought perhaps maybe if we discuss it and really highlight what COPD is all about and why it's so important for everybody to understand COPD in detail. So COPD, I will start by definition, is a heterogeneous lung conditions characteristic by chronic respiratory symptoms due to abnormalities of the airways, and that cause persistent, often progressive airflow obstruction. Now, I just wanted us to step backward. The definition of COPD has been evolving over a number of years. And one of the most important aspects of this definition is the progressiveness of COPD despite patients stopping smoking. It's still progressive. So that means those patients need a constant kind of follow and monitor. It's not one hit treatment and all is be fine. And then, of course, the other thing is looking at the chronic symptoms COPD, which is really there are only two, not many. It's dyspnea and cough. That, of course, the cough can be productive, and the sputum color determine whether the patient is stable or acute exacerbations. And then the third component, of course, due to abnormalities of the airway. Now, COPD can present in three different forms, either chronic bronchitis, bronchiolitis, or alveolar in terms of emphysema. So the symptom will vary based on that. Let's look at the burden of COPD. So COPD is underdiagnosed and underreported. Okay, if you look at the prevalence across the world, it's about 10.1 globally, and 3.2 million deaths annually. Now, if you look at the countries, so look at the graph, I think it's clear enough. If you look at the graph, there are two countries that actually contribute to more than 50% burden of global COPD reporting, and this is your India and China. And not that because they smoke so much, but obviously do more with the air pollution in that particular area. Now, again, I want to look at our own data in South Africa. South Africa also faces a particular severe COPD burden driven by a unique combination of risk factors beyond smoking. So in South Africa, about 20% of adult prevalence rates, and 38.3% emphysema and disease minors. So mining profits are number one, and of course, it having high economic and health care strain. So the nation's legacy of mining has created a significant occupational health crisis. Long-term exposure to silica and coal dust has led to extreme higher rates of emphysema and other lung disease among miners, contributing significantly to the national COPD burden. This combined with the high prevalence of previous tuberculosis, places immense strain on the healthcare system and economy. Now, look at these figures. Number one cause of COPD in South Africa is actually occupational dust. Mining is number one, then followed by smoking. And I always say, if you look at smoking, Cape Town probably would be our number one city of COPD in the country, out of the 9 provinces. And then tuberculosis, that's obviously more evident during 2004 to 2010, where the rate of HIV was quite high, and most of these patients having COPD. But perhaps now I hope the curve is coming down. And then lastly, the biomass, fuel, and pollution. Again, if you look at that, I always say if you're in doubt, drive next to township around 6 o'clock in the evening during winter. You will see the area, the shacks are all covered in smoke because there's people using coal or fire to heat themselves, and you could see the smoke rising up, and it's evident that you will inhale the smoke itself. Now let's look at the COPD risk factors. Of course, we say occupational exposure may account for 15-20% COPD. Mining, agriculture, textile, paper, wood, chemical, or food processing. These can all lead to COPD. Cadmium fumes can cause emphysema. That will be most in batteries. Socioeconomical status, poverty also increase the risk of COPD, especially this is more common in women. And genetic factors. Okay, if you look at genetic factors, one of the more common evidence will be alpha-1 antitrypsins. And then we look at other factors such as early life factors and exposure. That's maternal smoking, respiratory infection, and diagnosis. I think I'll probably discuss in the next slides. Tobacco smoking, nearly 80% of all COPD cases can be attributed to smoking. 15 to 20% of 1 pack per day. Those who smoke 1 pack per day means 20 cigarettes every day. 15-20% of them will develop COPD. And those who smoke 2 pack means about 40 cigarettes a day will develop, at least 25% will develop COPD. So there's correlation between that. So 1 in 1 pack, and then there's 2, and then more than 25% in 2 pack. Outdoor indoor pollution, biomass fuel, of course, 50% of COPD deaths in developing countries are from biomass smoke. 70% are in women. And this is really perhaps also very common in Africa. And as we get out of South Africa, where access to electricity, gas is not available, most of people using firewood. That synapses, I think, is something that is really, we probably don't see, radiologists see quite a more, but maybe we're not so clue about it. And that synapses really is, we're talking about mismatch of airway 3 caliber to lung size. And this developed early in life. And if you look at the picture here, you look at the trachea in A and B. They are quite very small tracheas, okay? And then if you look in C and D, the trachea size actually increases. In E, that's your bigger trachea. Now, the question that this was a retrospective study of more than 650,000 patients. So this synapses was significantly associated with the incidence of COPD with lower airway 3 caliber relative to the lung size, associated with a greater COPD risk. So maybe next time you look at your X-ray, please look at your trachea size. Lung function trajectory, this is also very important. So now, if you look at the lung function trajectory, is that patients that actually, you look at the 0 age and then up to age of 70. So most of your lung function peak between age of around 15 to 30 years. And those who reach a peak of about almost more than 90% of FEV1, they will have a trajectory with more than, and this is about 71% of patients, they will not have incidence of COPD. Also, the same, you have this group here that pick up at about the FEV1 peak at more than 70%, and you can see that yellow line there, the trajectory 2, 16.9%. So these people got no risk of COPD. The biggest risk are the 2 groups, especially trajectory 3 and 4. And you could see the peak there quite early, then there's a quick deceleration over here, FEV1. And these are the quite high risk of COPD in 3 and 4. So they have those patients, of course, they have reduced maximum attending lung function, may identify, and those individuals at risk of COPD. The incidence of COPD risk was higher when the FEV1 was less than 80% predicted before age of 40. Okay, so again, you look at 40 there, and you could see majority of these in trajectory 3 and 4, the FEV1 is quite very low. Now, what causes COPD? I think maybe let's just look at the inflammatory cycle in COPD. COPD is driven by chronic inflammatory response to inhaled irritants. This flow chart to illustrate the key steps in this damaging process. So number one, you have a trigger. You have a gun, you must pull a trigger for you to have injuries. So the triggers are normal inhalation, noxious particle, example, cigarette smoking, and things like biomass, and then mining dust. And then you have cellular infiltrations, that's activation of macrophage, neutrophil, CD8 T cell lymphocyte. And I will discuss further why HIV is known to be one of the causes of the COPD in South Africa. Mediators release, of course, once you have cellular infiltrates, release of mediators. Release of mediators, of course, that would be a proteases, elastase, and reactive oxygen species. And then what's the results? You have small airway fibrosis, mucus hypersecretions, and alveolar destruction, hence the symptom of dyspnea and cough with mucus productions. Now, so let's look at a close look at cellular inflammations. I mean, if you look at the number of inflammatory cells in the airway, increases COPD progress through different stages. This is based on goal, stage 0 to 4. So if you look at the innate immune systems, which is your neutrophils, macrophage, and eosinophil, based on the goal, you look at the goals here are highlighted based on color, blue, all 4 different colors. Unfortunately, men's are color blind, for the females can pick up very well. So if you look at the goal 4, if you look at goal 4, you see that actually all the cell lines are really involved. You can see your macrophage there. You look at the neutrophils and even eosinophil to some degree, which is supposed to be more predominantly found in asthma. And that's what later I'll highlight the need of why do we use inhaled steroids. And then adaptive immune system, of course, again, if you look at it, your CD8 is involved in goal 4 especially, but all the stages of COPD. Let's look at the T lymphocyte in COPD. Of course, the increase in T lymphocyte in the airway wall and organized into what we call lymphoid follicles. And if you look at there, that's the lymphoid follicles. And then you find that there's a shift in the balance of CD8 T cell ratio in favor of CD8 as a direct toxic effect. Now, if you remember patients with HIV, what happened that your CD4 drops and your CD8 increases. Hence, this increase in inflammation. When these people smoke, the risk of COPD just actually goes high. And that's normally it's become very difficult for us in the patients who are actual miners who work underground. Now, you don't know, is it the HIV that actually causing the COPD or is it the mining dust? So it becomes very difficult. Most of these patients, probably most of them really are put off the work. And the cytotoxic CD8 lymphocyte correlate with the degree of airflow obstruction. Now, a special case, HIV and COPD. In HIV, there's a chronic immune activations lead to a larger population of activated CD8 T cells. While fighting the virus, those cells accumulate in the lungs and cause significant bystander damage to healthy tissue, accelerating emphysema and driving COPD development, often at a younger age. Now, HDAC expression is reduced in COPD. HDAC really stand for histone deacetylase 2, which suppress inflammatory gene expression. So HDAC functions impaired by cigarette smoking and oxidative or nutritive stress. Corticosteroid can recruit HDACs and reverse the inflammatory process. However, in patients with COPD, there's decrease in corticosteroid responsive in those patients. So HDAC levels in the lungs decrease with increase in COPD severity. So if you look at these graphs here, you find that patient with the COPDs, mild COPD, the hashtag is quite functioning well as compared to that. And here there's no COPD. You can see the amount of hashtag is quite very high. In the COPD stage 4, the levels are actually almost non-existent. And theophylline was known to increase the hashtag, so there's the role of theophylline in patient with the COPD, especially severe COPD. Let's look at the genetic risk. Alpha-1 antitrypsin deficiency. I think in our practice, we have about 4 patients. So alpha-1 antitrypsin deficiency is a genetic condition that increases the risk of developing COPD, especially at younger age. The risk levels correspond to different genes, alleles, and result in alpha-1 antitrypsin serum levels. And in our practice, in severe form, you see the ZZ1 glial deficiency. I think ours is SZ, which is a high-risk group, because they're quite in their 50s. But if it's ZZ, tend to present more younger age. But what I would mention that most of the alpha-1 antitrypsin deficient, they would present like asthma. Most of them would be diagnosed as asthmatic, because most of the time, most people are not aware about it. So when to think about alpha-1 deficiency, of course, consider alpha-1 antitrypsin deficiency if the early age of onset is less than 45 years old, emphysema in non-smoker or minimally smokers, those with less than 10 peg history, when there's basal, panacina, emphysema, unlimited asthma with persistent airflow limitation, that's why I say most patients will be diagnosed as asthmatic, concurrent liver disease or cirrhosis, necrotizing pancreatitis, means skin involvement, and most of these patients have C-ANCA positive vasculitis. And also someone with first-degree relative with emphysema, bronchiectasis, and pancreatitis. So this is really the X-ray and CT patient of alpha-1 antitrypsin deficiency. You can see there the lung section. There's no lung marking on the bilateral lower lobes, and you could see that on your high-resolution CT scan. We completely know decreased lung marking. And you can see the significant air trapping with kind of flattening your diaphragm. So let's look at the airflow limitation, air trapping. Of course, in COPD, inflammation, fibrosis, and lumen exudates occur in small airways, and the number of small airways is decreased because of smoking-related or may reflect abnormality and early life lung development. Hyperinflation occurs early in the disease and is the main mechanism of exertional dyspnea. But hyperinflation, again, is not pathognomic with diagnosis of COPD. Sometimes some patients are told those were marginal features. When you do the X-ray, they tend to apply, the X-ray look to be more hyperinflated, but that's not good to COPD. That's not how we diagnose COPD. So you look at the normal airways, where airway held open by alveolar attachments, your elastins and fibers. In COPD, there's mucus inflammations, air wall thickening, peribronchial fibrosis, mucosal hypersecretion of goblet cells, hyperplasia, and decreased mucociliary clearance, and increased luminal mucus obstructions. And then, of course, you see disruption of alveolar attachment. That's what we call emphysema, and small airway closure, gas trapping. Emphysema and gas exchange in COPD, you can see there, that's your alveolar. They're quite dilated in the periphery, where you get a peribronchial destruction of the alveolar wall, loss of alveolar attachment, loss of elastic recurling, and enlargement of air space. And that's quite very nice and clear. And people still keep smoking. Emphysema, we normally see about 4 types. If you look at that here, you can see this central lobular emphysema. You can see that the central kind of cystic changes. And this is called panacina. You can see it's quite diffuse. And this is called paraseptal emphysema. You can see quite nice there. And this is bullous emphysema. So we see all of the above. Okay, and this one probably they will benefit from lobectomy if the bulla occupy more than 30% of the lung. Now, let's look at the spirometry in diagnosis of COPD. Spirometry is the cornerstone of diagnosis of COPD. So you first, when your patient comes to you for the first time, you measure the pre-bronchodilator, FEV1 FVC ratio. And if it's more than 0.7, not COPD. Major post-bronchodilator, FEV1, FVC, if volume responder suspected, example, low FEV1 or higher symptoms. However, if FEV1, FEV ratio is less than 0.7, major for your post-bronchodilator. If it's more than 0.7, you need to look at other diagnosis, consider asthma or other assessment. And if it's less than 0.7, then COPD is confirmed. Again, I would caution you that you must check the reversibility, because if the patients have reversibility, sometimes you give inhale steroid, you give them a bit of treatment, and then it reverts back to normal. Then again, that means it's not a COPD. So most times, sometimes we don't diagnose COPD on the first visit. We tell the patient, we put on a trial of therapy. After 6 weeks, then we review your spirometer again. If it persists, then you can either diagnose as a COPD or asthma with persistent airflow obstruction. The role of spirometry in COPD, of course, is to diagnose, assessment of severity of airflow obstruction, not for prognosis, for research purpose, follow-up assessment, therapeutic decisions, pharmacological in selecting circumstances, such as discretion between spirometer and level of symptoms, consider alternative diagnosis when symptoms are disproportional to the degree of airflow obstructions, and non-pharmacological such as interventional procedures, and identification of rapid decline. So spirometer, cornerstones. So it's important that people know to actually measure do lung function, especially the spirometer. The gold grading sensitivity airflow obstruction COPD based on post-bronchodilator FEV1. Okay, in COPD patients, FEV1 of less than 0.7, that completes your diagnosis. Then you now grade your COPD. Goal 1, mild, when FEV1 is more than 80% predicted. Goal 2 is moderate, when FEV1 is less than 80% prediction, but more than 50%. Goal 3, severe, when FEV1 is less than 50%, but more than 30% predicted. 4, very severe, when FEV1 is less than 30%. Diagnosis severity of COPD. Diagnosis is confirmed with spirometer. Severity is then classified into gold stage based on this degree of airflow obstruct limitations. Traditional gold stage, of course, that's why we say post-bronchodilator FEV1 FVC ratio below 0.7 is a diagnostic standard. Severity is then classified based on the degree of airflow obstruction. So I just want to mention something now. Once you confirm diagnosis of COPD, I think all the patients, when they ever come to follow up, there's no need for spirometry. You can actually give the patient inhalation and do a post-bronchodilator. And that's much more important than actually doing pre and post. It's expensive for the patient, and it's not necessary. But of course, as I say, gold COPD based on gold classification has been evolving. So now new terms have come to line, especially that was in gold 2025 and gold 2024. So there are two terms that the people need to understand. One is the new classification, of course, of pre-COPD and PRISMI, MM, which is recognized that patient can have symptom or lung abnormalities even with preserved FEV1 FVC. So PRISMs is stand for preserved ratio of your spirometer actually. Okay, so pre-COPD, you have symptoms plus risk factors, but normal spirometry. That's your pre-COPD. Symptoms plus risk factors, but normal spirometer. And then you have PRISMs. Of course, this is the FEV1 FVC ratio of more than 0.7, but low FEV1 of less than 80% predicted. So those patients, if you see our reports, we normally do include that in our reports. And then, of course, once you diagnose your COPD, you need to do your symptom assessment. So we're using two tools for symptom assessment. You can find this, the modified MLC Disney scales on Google, and it's got really about five points. MLC 1, grade 0. You ask the patient will tell that only get breathless with strenuous exercise. But probably if you ask people in this room, all of them probably having MRC grade 0. And then grade 1, I get short of breath when hurrying on the level of walking up a slight hill. And grade 2, I walk slower than people of the same age on the level because of breathlessness, or have no symptom for breath when walking up my own pace on the level. And then 3, of course, I stop for breath after walking about 100 meters or after a few minutes on the levels. Grade 4, I'm too breathless to leave the house, or I'm breathless when dressing or undressing. The problem that some can be subjective. Please switch off your microphone, please. Thank you. And then CAT assessment. We use CAT assessment. It's the second one that we use. CAT assessment obviously got about 8 items. It scales 1 to 5. And then we look at the scores of 0 to 40. Scores of less than 0 is low impact, 10 to 20 medium impact, 21 to 30 high impact, and more than 30 very high impact. And the minimum important difference is 3. Again, you can find on Google. Now let's look at the goal AB assessment tool. So obviously you do a spirometric, confirm diagnosis, assessment of the airflow obstruction, and assessment of symptom or risk for exacerbation. So you do a post bronchodilator if you're an ABC ratio of less than 0.7, and then you grade your spirometry. Is it goal 1, 2, 3, 4, based on what I mentioned, and then you look at the exacerbation history per year. If the patient has more than two moderate exacerbation or 1 leading to hospitalization, they're classified as E. And then you look at your spirometer. If your spirometer is about 50, let's say goal 2, then you can call them as goal 2E. That's why sometimes you see us saying goal 1E, B, C. So normally that's you see on our reports. And if someone goes 0 or 1 moderate exacerbation, not leading to hospitalization, then you put them on A, B. But then again, then you look at the MRC in detail. So if it's 0 to 1, we put them A. If it's more than 2, then we say B. I hope that is very clear, because most of us came from the goal where there was A, B, C, D. So it's involving, that's the beauty about COPD. There's never a dull moment. So next year, probably you find that pulmonologists will get bored again, then we sweep it around. Board index, this is very important, composite score, which is really looking at the prognosis for the patients. B, BO, both stand for body mass index B, and O stands for degree of airflow obstructions, which is FEV1, and D for dyspnea, MRC, and E for exercise. And again, then we look at them, we grade them based on the score, okay? And that's obviously will tell you that now, if you look at this this graph here, you look at the FEV1 stages 1, 2, 3, and you could see there, it's mortality with the stage 3, mortality become less than 35%. Additional investigation to consider in COPD, of course, we do test for heartburn and trypsin screening. Obviously, that's really based on the all the factors that I mentioned. Imaging is important. X-ray really has not major role in COPD. Probably just show you hyperinflations. That's all, but might not give you much more detail other than that. Lung volumes and diffusion capacity is initially important in diagnosis of COPD and also for those for intervention. We do normally look at the residual volume, which is very important, of course. That means tell you about the degree of air trapping. Oximeter and blood gas measurement is very important, which I'll discuss later. Exercise testing is very important, 6 minutes walk test especially, and composite scores such as body index and biomarkers. Use of CT scan in stable COPD is, I think, is very important. It's used for differential diagnosis, frequent exacerbation, excess cough with sputum production, raised concern from bronchiectasis or typical infection. So symptoms are the proportion to disease severity based on lung function test. So all my patients really have to get CT scan. And then lung volume reduction surgery, endobronchial valve therapy may be therapeutic option for patients if they demonstrate post-bronchodilator FEV1 between 15 and 45%, and the evidence for hyperinflations. I'll tell you why. FEV1 of 15%, think about that. It's extremely very low. But those patients will go through general anesthesia and actually valve done, and they can be extubated safely. So again, maybe later next presentation, I'll discuss about pre-operative assessment of patient COPD, who should be allowed to have anesthesia, who should be denied anesthesia. Because in South Africa, everybody with COPD completely is not a candidate for general anesthesia, which is really a lot of bullshit. I think perhaps those patients must be sent for pulmonologists for proper assessment. Lung volume reduction surgery may be a therapeutic option for patients with their hyperinflation, severe upper lobe, predominantly emphysema, and low excess capacity after pulmonary rehabilitation. Lung cancer screening, also very important. We talk in this setting, we talk about low dose CT scan, which discover actually finding it to exclude cancer. Goal for treatment of stable COPD remains one is relieve symptoms, improve exercise tolerance, improve health status. That's symptom reduce. And then, of course, and prevent disease progression, prevent and treating exacerbation, and reduce mortality, means risk reduction. Management of COPD, of course, you need diagnosis with your symptom, risk factor, and spirometer. And then review, of course, you review your symptoms, exacerbation, smoking status, exposure to other risk factors, inhaled techniques, and also you do inhaled techniques and adherence, physical activities and exercise, need for pulmonary rehabilitation, self-management skills, breathlessness, and written action plan, need for oxygen, NIV, lung volume reduction surgery, palliative approaches, vaccination, management of comorbidity, and spirometer. Adjust, of course, is used for adjustment of the pharmacotherapy and non-pharmacological therapy. Initial assessment, of course, you do your FEV1, goal 1 to 4, symptoms, CAT or MRC. Those are really well studied and they're very quite evidence-based. Smoking status and blood eosinophilia counts, very important. Alpha dropsyn if suspected, and comorbidities. So initial management, again, it's really more to do with the smoking cessation, vaccinations, active lifestyle and exercise, initial pharmacotherapy, self-management education, such risk factor management, inhaled techniques, breathlessness, written action plan. So now, this is normal what happened. Now, if patient come in, they have two moderate exacerbation or one leading to hospitalization, they're grouped in position E. What treatment do you give them? You give them LABA and LAMA, okay? And then you consider LABA plus ICS if blood eosinophilia more than 300. I'm not going to go to details about which inhalers to use. I think this is we're not promoting any pharmaceutical products. So the choice is really how compatible you have to assess a patient, how easy can a patient actually use the device. If they're common with the 0 or 1 moderate exacerbation, not leading to hospital admission, so they fall under group A. And then group A, really previous studies support the use of LAMA in group A. In group B, you can use LAMA and LABA. Key point for inhalations of drugs, of course, when the treatment is given by inhaled route, the importance of education and training in inhaled device technique cannot be overemphasized. The choice of inhaler device has to be individual, tailored, and will depend on access, cost, prescriber, and most important, patient ability and preference. My argument is that don't prescribe COPD treatment if you don't know how to train the patient to use it. Otherwise, it's just a waste. You must make sure that you will train the patient yourself, because even the pharmacy, the pharmacists, they struggle to do a proper training. And then as a result, this patient stay at home and they don't know how to use those inhalers. And as a result, time is lost in actual recovery of the lung function. It's also essential to provide instruction and to demonstrate that proper inhaler techniques when prescribed a device to ensure that inhaler techniques are adequate and to recheck at each visit. That's why in my practice, every patient, they need to come with their inhaler techniques, the inhaler devices. And if they come without one, I charge them, but I don't see them until they bring them their inhalers, because you have to always check that they are using it correctly. Inhaler techniques should be assessed before concluding that the current therapy is insufficient. Chronic COPD, again, is just really a summary of what I discussed. The most important, I want you to look at the bottom here. We look at the roles of inhaled steroids in patients with COPD. Consider for group E patients with blood eosinophilia of more than 300 cells or the history of frequent exacerbations. Malignant patients currently on LAMA and ICS. So patients who are taking LAMA and ICS, how do you manage them? Patient current on LAMA and ICS, of course, first, no current exacerbation, previous positive treatment response, low symptom load, continue treatment. If high symptom load, consider escalating to LAMA, LABA, and ICS. No relevant exacerbations, consider changing to LABA, LAMA. So you remove ICS. If they're stable, remove ICS because ICS increases risk of pneumonia. And if they got current exacerbation, do blood eosinophilia if it's more than 100, or then you consider LAMA, LABA, and ICS. What are the advanced procedures for severe COPD in severe emphysema? For highly selected patients with severe emphysema, surgical or bronchoscopic procedure can be significant, improving breathing, exercise capacity, and quality of life. So we have two options. We have a lung volume reduction surgery. Lung volume reduction surgery is a surgical procedure that removes the most disease, hyperinflated part of the lung to allow healthier tissue to expand and function more efficiently, typical for patients with upper lobe, predominantly emphysema. And then wide bronchial valve treatment, this is really done by pulmonologists. We are very busy establishing a center to perhaps we should be able to offer the bronchial valve treatment in the next 18 months. Once we get all our patient profile, coordinations, pulmonary rehabilitation, is quite a very complex, but you need a system that functions properly. So we're quite very busy with that. We're doing a lot of trainings. Within 18 months, we'll have a center in Victoria that will provide the service of bronchial valve treatment. So it's really a minimum invasive procedure involved placing tiny one-way valves in the area of the disease lung lobe. Those valves allow trapping air to escape during exhalation, but prevent new air from entering, causing the lobe to shrink, creating space for healthier lung to expand. So I just wanted to discuss this dynamic hyperinflation during exercise. I think it's very important for patients with COPD to understand, and the physicians and GPs to understand. So dynamic hyperinflation is the key reason why COPD patients feel short of breath, fatigue during exercise. Is dynamic hyperinflation. So most of these patients develop anxiety because they can't breathe. And sometimes we thought that this patient got anxiety, but actually it's really more to do with the fact that their minimum ventilation increases and their air, the volume of the air actually increases. So it's really a vicious cycle of air trapping that severely limits breathless breathing and put a strain on the heart. So what's the vicious cycle of air trapping? So you're having airway obstruction. We call incomplete exhalations, air trapping, and lung overinflate. So the lung becomes quite bigger. Impact on breathing, diaphragm is flattened because the lungs are so big, the diaphragm flattened and weakened. Lung becomes stiffer, making it harder to inhale. And also the stomach is full down. Those patients even cannot eat because they feel full all the time. Hence they lose weight. Limit excess capacity, and most of these patients cannot even do exercise. The body cannot get enough oxygen because the lungs are full of air, leading to severe shortness of breath and fatigue. This forces the patient to stop exercising, and they end sitting down, and out of blue, the risk of actually dying also increases. Quickly about managing exacerbations. Of course, we have an acute exacerbation as serious event. This treatment is the treatment pathway based on the GOLD guidelines. Is designed to minimize their impact and improve patient outcome. Mild exacerbations, that's what you do, increase dose or frequency of short-acting bronchodilators. And moderate severe exacerbation are demonstrating a short course of oral steroid, easy, prednisone 40 milligrams daily for 5 days. And you consider antibiotic only. Again, mark this point. You consider antibiotic only if all 3 cardinal symptoms are present: increased dyspnea, sputum volume, and sputum purulence. And when your CRP is more than 40, not when it's less, or PC is quite high, more than 0.5, then you can consider antibiotic. When you're also having 2 cardinal symptoms are present with sputum purulence being one of them. Again, then you consider it, and patients require mechanical ventilation. Then there's indications, but not for everybody. So severe respiratory failure in COPD, consider non-invasive positive pressure ventilations and provide oxygen to maintain SATs between 88 to 92, but not more than 92, guys. Because sometimes you work to patients in ICU, find that they're having COPD patients are having SATs of about 100%. It's really defeat the purpose. The goal AB patient assessment, modern COPD management uses patient-centered approach, categorize individuals based on their symptom burden and history exacerbation to guide initial therapy. Group A, low symptoms and low exacerbation risk. Group B, high symptom and low exacerbation risk. And group E, a high exacerbation risk and any symptom level. And again, common comorbidities in COPD, we see more cardiovascular disease, most common. Lung cancer is really much, and osteoporosis is very, very important. And if you look at our presentation, Dr. Godina did a very big presentation on osteoporosis. So those patients actually, they require DEXA scan. All COPD patients require DEXA scan. And anxiety and depression is also very common. They need to have counseling. That's why you cannot do anything until you have a psychological support, get physiotherapy support. You have to have a complete system built up to support patients with COPD, and I hope that we should be able to do that in 18 months from now. Prescription supplemental oxygen to COPD patients. Obviously, you need the indications. You look at atrial hypoxemia defined as a PO2 of less than 55 or SALTs of less than 88%. Or when PO2 is more than 55, but PO2 less than 60, and with the right heart failure or electrocytosis. Now, I want to mention something clearly. These indications of the right heart failure, or what we call as pulmonary, depends where are you residing in South Africa. If you're not residing in Western Cape, in where this is in the sea levels, most of these patients are likely to develop pulmonary. Pulmonary is more common in the areas with high altitudes. When I was in Netherlands, most of the patients in Netherlands actually they don't have pulmonary, very few or even none. Okay, so but if you look at South Africa, most of the patients who come to our practice have already some evidence of some pulmonary, and that's more to do with really with the height. The height plays a critical role. So if the fact that you don't see pulmonary in Western Cape for someone who residing there throughout their lives, that does not mean that they don't have a severe COPD. So most of these patients can't tolerate hypoxia quite a lot because in the sea levels, there's high tension, the high level of oxygen tension. Prescribe supplemental oxygen, of course, and you titrate it based on the saturation levels. And most of the time, you want to achieve saturation between 88 to 91, but not more than that. You check in 60 to 90 days to assess if supplemental oxygen is still indicated and if prescribed supplemental oxygen is effective. So, preventing exacerbations, what are the tools that we have? An exacerbation of flare-up is an acute worsening of symptoms that can accelerate disease. And then, of course, progression. Prevention is a key goal of therapy, relying on the multiple facet approaches. So one, patient needs to stop smoking. Smoking cessation is the single most effective intervention. 2, vaccinations. Annual flu vaccines and pneumococcal vaccines and covered short, but now probably not much indicated. But pneumococcal vaccines, obviously, we normally use about, I think currently Pfizer actually launched another one, but I don't know whether we are getting South Africa now. But in the past, we will give what we call the stimulator vaccine prevent to the teen first. Then after 2 months to a year, we follow that by pneumovax. And you repeat that after age of 65. It's not done every 5 years. Okay. And then, of course, and then in South Africa, looking at our center midstream, we have a lot of people coming with H influenza B bacteria. So we also give them influenza B vaccine. Also because that's one cause of the exacerbation. And now we do have vaccines for RSV virus, which is very important. Again, that's now available in the country. We should be able to prescribe those. Pulmonary rehabilitation is very important in South Africa. We currently don't have really well-developed center for pulmonary rehab, but we're in the process of establishing one and hoping that that would actually improve the quality of life. And optimal medication adherence also to prescribe treatment, inhaler techniques that cannot be overemphasized. And on my last slides, which intervention work in patient treatment COPD, of course, with there are few of them, those for reduced exacerbations. The evidence support the use of all long-term bronchodilators, LAMA and LABA, okay? Inhalations like pharmacodulin, those does not work for long term. They're very good only exacerbation. So they're not indicated as in long-term treatment of COPD. So stick to LAMA, LABA. But LAMA is far better than superior than LABA. I see combination triple therapy, very important with those who use eosinophilia. Roflumilast was my favorite drugs and long-term azithromycin. But currently, the Roflumilast, which we have was sold under trade name of Daxus in South Africa, and that has really been discontinued, but we still get them under Section 21. And they really just magic for my patient. Smoking cessation cannot be overemphasized. Vaccination for pulmonary rehab cannot be overemphasized. And of course, selective patient, 1 out of 10 patients that we actually assess for lung volume reduction patient actually benefit from the endobronchial valves. And I think soon we'll be offering the service in Pretoria. And of course, reduce mortality is another important thing. Smoking cessation is key. Triple inhale therapy does reduce therapies as ICS, LAMA, and LABA. And we now having pumps that actually can deliver all three in one shot. Long-term oxygen therapy in severe hypoxemia means somebody with the SATs of less than 88, again, as I discussed, okay? And NIV in stable hypercapnia, lung volume reduction surgery in selected patient, and pulmonary rehabilitation. Thank you. And that's already the end of my presentations. Any questions?
Thank you. I thought that was a very good presentation. Nice and clear and easy to follow. And it's something we see on so often that we all actually need to know this. We're treating patients. I see there's lots of clapping. Are there any questions from anybody online?
I think while everybody thinking, I just want to answer here. I would do a special presentation regarding vaping and e-cigarettes. That I would do it. Probably will be my next presentation. So I don't want to touch with it because that's a big topic. If you look at the COPD, just took 47 minutes. So I didn't want to do injustice to it, but I would present it properly again. So we'll inform you when we present again. Then what else? Please, guys, do subscribe to our YouTube channels. It's free, and also obviously and links in, and let's keep the interaction talking. If there's any communication, please let's chat about it and that. Any questions?
The YouTube is called Sanocare Breath of Hope.
Aerobic. Well, look, it's very good. We have a last week presentation about it, and it's definitely work. Provided it's normal, I always recommend that the physios must get involved in it, and they will help in training the patients because it's part of pulmonary rehabilitation. Thank you. More questions? Okay, it's coming. That will be the next presentation. If there's no question, can I say thank you? And thank you guys for joining us. Remember, we have presentation on Wednesday and Thursday. Please join us also on Wednesday. The link is the same link. Yeah, and also you got you also do get CPD points for that. Thank you. And then I think probably next 2-3 weeks, Dan is going to review a book for us, which we're going to take different thing about. He will tell us about new book published by University of Pretoria, which we don't really disclose it for now, but he will talk about it and review the book for us.